You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
Audra's over here shining up, so she glows. You're already out gonna do Brett and I, so don't worry about it.
No.
Yeah. So Brett, this is, I think you've been on this podcast twice since we call it the Farmcast, but I have like podcast ADHD with the name changes because you were like one of the first guests way back when on my original podcast, which I don't even know that was called True Health or something now, but we got Brett Winchester on here, who has the Gestalt Education podcast. We have Audra Lance, who has Mind Your Body, podcast. So we got a bunch of podcast hosts. I mean, we're basically all famous. If you haven't heard of us, that's your problem. But Dr. Brett Winchester is joining us today. We're going to talk about a menagerie of things. We have no clue where it's going to go. I've got a list of questions, but we'll just kind of have to, figure that out as we roll. Audra, you're kind of buzzing a little bit, maybe not from wine, but your speakers. So let me see if I can get something going here.
Not today, but look at my coffee mug. It's very fitting.
Oh, I like it. That's, definitely fitting. I'm going, we just got have you guys heard of the Toshibo, TCHIBO coffee machine? It's like a grind and everything all in one. It's elite status in our office, just got one, and everybody is super excited. So I'm probably going to be broke in about 6 months, but
it's all right, worth it.
Yeah, totally. So was last year 20 years in practice, or was it 2 years ago?
I'm pretty sure I'm in my 22nd year, I think. So
Okay.
Yeah, it's close enough. Yep.
2 years. So over 2 decades in practice. Let's lead with a huge question. What's changed? Like, what are the biggest changes you've seen in your practice style? I know we could go way far in the medical realm, but in your practice style and our kind of group of practitioners, what's been the biggest change?
I think the blend of what the evidence was telling us and how that is obviously critically important, but then kind of learning a valuable lesson that I wasn't going to fix everybody in two and three visits. That's probably the biggest change looking back at my career that I had to learn the hard way. I always say that, being in a relatively small town, having to always see my patients and run into them and then, tell me they've done something else or tell me that, they weren't doing as good as I thought they were doing. And then that was really, really humbling. And then from that, I really, really learned how to manage cases way better, I feel like. And I feel like when you're young, you do manual care, you teach rehabilitation, of course, and you cut the patient loose and you just automatically assume that they're fine. And the reality of it is a lot of our cases require management, even in the evidence-based and functional side of things. And I mean, even people like, Gray Cook, Shirley Sarman, other people have talked about this also. So it's not just like our faction of people that have come to this conclusion. It's, of course we want a minimal dosage, but then, most of us, we go get our hair cut once a month, and you could cut your own hair, but usually you have someone that you trust to advise you on that. And I kind of think of like ourselves in that role to kind of guide them through the musculoskeletal or the functional medicine, whatever it might be. And I feel like a lot of people are afraid to say that. And I just feel like anyone who disagrees with that, I kind of feel like they're not actually in the grind every day that's like having to manage these cases. So, and I just think like finding that perfect sweet spot with every patient is kind of the skill of practice. But if you made me say it would be that, the other thing would be like, I am enamored every day with the ability of the human body to adapt and compensate to things when they're not ideal. And I think you got to be careful when you're doing a job like we're doing to make sure that you're not working on an adaptation and compensation and really pride yourself and really getting after the actual cause of the problem. So those are some things that kind of stick out. It's probably a little bit harder than I thought it was going to be, maybe when 20 years ago. It's
Hence the 2 to 3 visit, fix everybody mindset. Yeah.
yeah, because you got the human factor. You're dealing with human beings, and now more than ever, humans are going through really difficult things with social media and just all kinds of crazy stresses. So there's a lot of complicating factors that make our job harder, I think. So
Yeah. You had mentioned in there, management, the 2 to 3 visits is maybe not, well, it's not realistic. It's not a maybe. A lot of students and new docs and even docs that have been practicing for a while kind of get coached on like, hey, you need to hit a certain number of visits for a treatment plan. And like, this is kind of the average we want to look at is, because we have a lot of docs and students that listen to this. Is that something that you guys actually look at from a practice model? Or is it kind of just like, man, whatever that patient needs, it's a case by case basis and that's what we give them? Or are you kind of like, hey, man, we're running a business too. Like, we got to make sure we're not just booting them out the door. So how do you guys approach that?
yeah, well, I mean, I think everybody wins in the model that we're talking about because, I mean, never do we talk about like just the financial side of it. It's always really what the patient needs. Now, I will say we do have parameters early on. So, just as an example, if you saw a new patient, most of us are here at our office are going to see that patient usually 2 times a week, unless it's like an acute disc derangement or something like that. And then we reevaluate them at the 3-week mark. And I never overpromise. I just say in 3 weeks, we'll reevaluate. We'll see where everything's at. But really, 10 years ago, I really went all in on function. And I was kind of a hypocrite because I was telling people like on the seminar circuit that I was treating function. But really, at the end of the day, I was kind of a pain chaser, quite honestly, if I'm honest with myself. So I kind of just had that moment in frustration where I was like, you know what, from this day forward, I'm not doing that at all. Like, I am going all in on changing the functional audit of all my cases. And if I do a good job with that, I know that the pain is going to closely dovetail with that. And I just went all in on that. And when I say that, people think that, I'm not being empathetic. Of course I'm being empathetic. And we're also classifying our patients, like whether it's the centrally mediated case with like Annie O'Connor, for example. So that's all kind of built into the cake. But I just felt like I was really over reliant subjectively on what the patient was telling me on how their case was. And the second I made that switch, it was the most liberating, amazing feeling in my life. Because if you think about it, it kind of takes all the pressure off, really. It's like, all I can do is try to be world-class in my ability to change the function of the case. And if I'm good at that, I also sort out who's my centrally mediated case because all the audits are changing, but they're continuing to tell me that they're no better. And then the other thing is like the structural case that you and I aren't going to help. So if I have somebody who's got like a femoral tabular impingement and a labral tear, the only way that I know if that patient's going to get better is by doing a trial of care. The severity of the MRI findings, they tell us something, but they don't tell us everything. Like James Andrews says, if you want an excuse to do a surgery, basically do an MRI, Yeah. So the severity of the MRI means something, but it's not the end all be all. The trial of care is how we know whether or not we need to escalate, further medical treatment. So we are in a position to be the most amazing gatekeepers because the surgeons love us too, because if you get done with us, then like it's like don't send them back to me. Like we tried everything. We changed function. They're ready for surgery. So I think we're really in a great position being, a chiropractor, physical therapist, or ATC to be that initial gatekeeper. The hard part is it's hard to find people in the world that are really good at that initial trial of care. So, like we all have, people that contact us and are like, oh, who do you have in a certain city? It's like, oh. Like, because you need them to be able to give a really good trial of care. So,
Yeah.
So go ahead, Audra.
Just along with that, I think that's really key. And like for the students and doctors listening, because we have some of these conversations in the background of all of us. So just to like clarify and side note, y'all, I mean, we're talking to one of the industry leaders here. He's helped, Dr. Beau and I, like from students through now, I still call him on a regular basis and we talk through, cases and everything and even business stuff. So, I mean, this is such a treat. Like, thank you for coming on here and like sharing your wisdom. And thank you for being such a good mentor and friend and all the things. Like, we're so excited to have you.
I'm excited to be
So you were saying, about like changing to function. And I think where sometimes students, and which is so true, like treating on that and using your audits heavily. But from like a patient care standpoint and being the doctor and building that relationship, you also talk about the it factor a lot, which we can get into. And I think managing, yes, in my head, I'm doing audits and functions, but the patient still needs to be heard. Like you need to convey to them, you're hearing what they're saying, maybe touching the pain, touching them where it hurts. But in your head, in your treatment plan, you're like, okay, I'm really functioning, but we're not separating of, hey, don't even listen to the patient of, oh, it's my knee and why are you treating my shoulder? Like you need to have that patient education and like that, like you're saying, that empathy and everything. And I just wanted to hit a little bit more on connecting those dots, because sometimes I think in seminars it gets lost of, oh, I only do function. I don't listen to what they say. I kind of tell them to shut up and it doesn't matter.
No, and I mean, I definitely, and we work hard like around here is, you can call it customer service, you can call it factor, you can call it whatever you want, but I think like it, and you could also call it tough love, where you're listening really, really well to the patient. But it's also, I think it comes back to also like present time consciousness, which is very few doctors in the world are giving you 100% of their presence when they're with the patient. So I feel like when you do that, then you really are forced to be in the moment and do a good job. And I feel like that's one thing that people don't do a very good job of. But I think that actually helps in that, because although I'm beating this functional drum, I don't think any of my patients would tell you that I'm not a good listener and I'm not, hearing what they're saying. I just think like we've all been there too, where like you walk into the treatment room and the patient's wanting to tell you they're no better.
Yes.
And you slowly, subtly point out something that's quite a bit better. And then they completely change their tune and they're like, oh, actually, now that you said that, things have been quite a bit better. So I think that sometimes the changes in our world happen subtly. So they need to be pointed out. And then, but in saying what you said, I would 100% agree with you. There's a lot of like little soft skills that go into getting people better. Like the rapport is established in the first 13 seconds you walk into the treatment room. And they've actually found that 93% of it is actually nonverbal. So it's not actually what you're saying to the patient. It's, do you have a smile on your face? Do you look like you're too busy? And then the other most important thing that somebody in this world can offer to your patient is reassurance. So, and this is why certain people who we would consider to be not very good at what they're doing, they are capable of getting miracle after miracle. And then you have like some evidence-based chiro who's a complete superstar from a knowledge standpoint, and they have a little tiny practice that no one knows about. It's the people that are in more on the evidence-based side of it, like we're in, we have more tendency to question even ourselves. And that inadvertently gets transferred to the patient without us realizing it. So sometimes, we need to, in our world, have a little bit more certainty and confidence. And I think the soft side of being a good physician, there is so much there, Audra. And like I've spoke now over the last 3 years quite a bit on this topic, which I don't talk at all about any of the clinical things, but just all the little things that make you a good healer, and being empathetic is one of them. I look at some of the other people in the world and you kind of see like what their shtick is. For example, like Annie O'Connor, the best listener I've ever been around. Stu McGill, the best coach I've ever been around. Mike Shacklock or Thomas Shaw, they know research really well, that they convey that to the patient. Therefore, they're very impressive in confidence because they are explaining the research to the patient. And I feel like everybody's kind of you got to kind of find your own way, but like that's your it factor. And you're doing a good job when you're exploding your practice. Like if you're not exploding your practice, I mean, you got to be able to take one patient and turn it into 10. And if the patient's leaving you wanting to refer you 10 people, then you're probably on point on on your education. But like, I think it is helpful for most of us because we do err too much on asking our patients how they're doing, to maybe like almost mind up yourself into the functional side of it. That way you can just start like kind of thinking that. or just kind of imagine, like, let the body tell you how they're actually doing. And I think that can be helpful for the young clinician who may be shading too far into the subjective side of it, which was me, by the way. I mean, I have the scars to prove it. So I'm, I'm speaking from experience.
And I think
so.
that's like having a little bit of control over the appointment. And like, can you talk more into that of like, how do you go into a room and make sure you have control? Because we've all been then in that situation. I still get into it today of like, whoo, I'm losing control of this. Like they're taking over. Can you talk a little bit more about that?
Yeah, I mean, if you go through your schedule today on everyone that you don't want to see today, those are all people that you're not controlling very well, shockingly. So
Right.
I think that that is where, and if you get around the people who are really good at this, you'll see they do a good job of establishing the control, because your patient is, like, they're trying to manage something. Like your analytic patient, they just are too close to the situation. And it's like I tell them, like, if I'm seeing them, like, let's just say for functional medicine, it's like, you're not going to know more than me on this. Like, I know you think that you do and you've Googled and stuff like that. So like, quit trying, like, trust me to do that for you. And I think, establishing that, and I think to that point too, Audra, would be, because you got to be confident, you got to be certain, but you can't be cocky. So you're like playing in that
Yes.
like little delicate world there. But I think doctor certainty is so important that I don't even have words to describe how important that is. And I feel like the orthopedic surgeons are so good at that. So they basically look at an MRI and it's so clear in their mind, like what needs to happen. So then you do a surgery and then, the patient's all bought in. What do? We will hem-haw about, well, I think we might be able to help you. And like, you're not even confident about the functional findings that you're looking at. If you could just convince the people that are in our world that, like, if you could get it as excited about your functional findings as the orthopedist is on their structural findings, you're going to see a completely difference in the compliance to whatever you're recommending to the patient. But for some reason, because we question so much, and I guess we don't believe it ourselves, that part's kind of challenging. But I to your point, and I work hard with our people here and our interns. Like, if you're not confident in the beginning, fake it until you have the confidence. But like, that's where, like, some of us need to do some soul searching on the technique systems that we're bought into, because you're not confident and certain because you're not getting the results that you're that would make you confident and certain, But
Well, and to
if
dig
you've
in,
seen some
to dig into
surprising
the,
talent. Oh, sorry, Beau.
I was just going to say because we keep talking about this functional approach, which we all assume everybody knows what that means, right? And again, there may be patients listening, whatever. A lot of times I think, and Brett, you have way more interns flowing through your office than I do, but sometimes it almost seems like the expectation of some people that are a little green is that the functional approach would be like you're always treating something that doesn't look like it would apply directly to what's going on. So like, you have to be treating away from the side of pain. It has to be some like almost like, how did you pull that rabbit out of the hat? So I just wanted you, maybe that is the case. Maybe. So how I always kind of like frame this is, if somebody walked into my office, I bet 99% of the time they'd understand. They'd just be like, oh, I kind of get what you're doing. They wouldn't be like, why were you working on their big toe to like fix their left wrist pain? So do you feel like that is the case, or do you feel like, man, it's just a grab bag, it's patient presentation, or like, because I think that gets coached into people that, like, if you are treating too close to the side of pain or local function versus like distal function, that's almost like a shameful thing to do.
No, and I think that's a misconception. I do think we tell those stories, though, because they're very inspiring for people to make them
Yeah.
look globally. And I think, like, it depends which technique system that we're talking about. For example, like MDT, which is, a big part of, one of the things we do here. I mean, that is 100% a local treatment. That is like taking the painful joint and seeing if there's a directional preference. If you're working with athletes, you're probably going to have shockwave and laser. All that treatment's going right to the area of complaint. The soft tissue techniques are often, they don't have to be, but they're going to the area of complaint. But then like if you have like in your triage system, like DNS, for example, DNS is really kind of unplugged from where the symptoms are and really like trying to find like where the key link is. And we work hard on, so like we might be doing something locally because you got to play the game tonight, but then overreaching, we're still working on the big global finding. But I think like the big thing when you're young to kind of appreciate is that you could do local treatment and turn the intrinsic muscles on in the foot and completely change the range of motion of the hip. Or you might not have that miracle happen, but understanding if you're on the key link, whatever the key link is, you're going to have the greatest effect on all the audits across the body. So that's how you actually know that you actually are on the key link. So, you know, that's the human body's an absolute puzzle. But I tell our young, until you gain your confidence, treat locally. You'll have, if you took the next patient that walks in who's got a sore shoulder, do a subscapularis ART move, do a three DNS corrective exercises, mobilize their CT junction or manipulate there. And if you take 100 patients, 90 of them are going to get better with that approach, you know? So, but like, as you get better and better at this, you get more of like a sniper where you know exactly what you need to be doing. And as it turns out, the more patients that you see, the more money you make. Funny how that works. So like being, you know, efficient with your assessment actually rewards the people who are bought into this, because you're still getting a world-class result as you're seeing more people and you're making more money, but I guess you could argue that you're helping more people too. So it's not just a selfish money thing.
Well, I think you're also buying exploratory real estate by building rapport and reassurance in those first few visits if you do treat locally, just because you might get lost if you try to jump to this like, you know, extrapolative functional approach. And I think that's what a lot of new docs need to do, is like make sure that the person understands what they're doing, that they can have a result. And then you can be kind of playing around on the fringes, which they'll never even know or be aware of what you're doing. And then little by little, you're like, you know, kind of like a researcher, like, oh, I kind of made this correlation. You know, that takes years. And, you know, some people, might be better than others at pattern recognition or, you know, just the manual skills or have an intuitive approach to it. But I just feel like I wanted to ask that question because I think that's kind of the story gets built, that you have to be like treating things that you wouldn't almost like put together to be considered a functional approach. And I think that leads people very astray.
I would not know that's like what people say. And I don't think that's the case, honestly. I do think though, like most people, you know, like especially if you're young, that's where like I love our buddy, you know, Gray Cook, because Gray Cook has made people look globally, you know, like no one's made people look more globally in the world of what you and I do in the last 20 years than him, because the SFMA is a way, I'm not going to say it's the end all be all by any means, but it is a way to make you, a young clinician, look globally and then gain confidence on like finding a problem that's away from the side of complaint. But I think also like if you can buy into the idea that in our first year of life, if everything's developing the way that we want, that the body it's such a pure, perfect point. You don't have any trigger points. You don't have any joint blockage. Your soft tissues are perfect. If you did a neurodynamic test and the patient was able to relay the information, all of that would be perfect. In my mind, what I'm imagining is I'm restoring every single patient that I see back to that state. I could have an 80-year-old stenotic patient, for example, that I'm going to see today. That's never going to happen, of course, but in my mind, I'm imagining that's what I'm doing. And I feel like your patients will be better off if that's kind of your mindset. But I think also like in a treatment plan, you have your chiropractic miracle, which is you've done one adjustment. We've all been there, and like you've changed someone's life for whatever the reason is. And then you have whether or not on the other end of the continuum, they would require an orthopedic intervention, which is less than 1% of the people that we see. So in between there, you have what I call the functional black hole. And that is where the evidence-based crowd is doing a horrible job of managing. So you didn't get a miracle day 1 or day 2. You know they're not going to surgery. Your miracle now needs to occur over a 3-month period. And you can still get a miracle, but it's just not like that overnight miracle. So what do? You slowly start chipping away at function, you know? And that's where like the clinical auditing process helps you so much, because you're basically getting the roadmap on what you need to be changing as you're moving them down this functional journey. And then as it turns out, you get your miracle, but you get it 3 or 6 months later, and you get it the old fashioned way through hard work and home exercise and, all the things people know. It just, we become so into like instant gratification that like, if something doesn't work for a day, we think we're doing the wrong thing, which is a huge mistake. And changing function takes time. And the analogy I use my patients is like, you don't put braces on your teeth, wake up the next day and be like, oh, my teeth are straight, rip off the braces. No, it's like a 2-year process of your teeth being sore. And and then you wear a retainer after that. And like some things just need and require a little bit of management, I feel like.
Yeah. Which, I mean, you mentioned DNS, and again, most people listening probably know what that is, but you're an OG of DNS. Kind of got into it early when the original crew was going back and forth to Eastern Europe and back. Again, we led with the question of kind of what's changed in your clinical perspective. I know DNS has changed massively, from not even being called that to now being called DNS, and then all the changes that have occurred in between. But with our upcoming course that we're, hosting you for in April next year in Nashville, like what have been the biggest changes or the biggest change, I guess, in DNS since like you first got involved with it? And I know there's a ton, but is there 1 or 2 things that stand out to you?
Yeah, I mean, we've just gotten way better at teaching it. And I feel like I think we unplugged a little bit from like the perfectionism of human movement to where we feel like, okay, this joint has to be like in this specific position. Otherwise, it's a problem. And I do feel like early on that created a little bit of a problem because people would leave a seminar, like people would be afraid to move literally because they didn't think they were moving like in the ideal strategy. So I feel like unplugging from that was critically important. And then DNS is a very active treatment approach versus originally it was very passive because of the heavy influence of reflex locomotion. And I think that like those are the big things. And I think since it's still in its infancy, so really we're still like, we're not even at 20 years old yet. So, I mean, by the year, and we were just with Pavel here recently here in St. Louis at the DNS World Congress, and he's always changing also, so I mean, it's kind of an exciting time in DNS because people are all over the world doing different things, and we're all working with different patients and athletes, and we're coming back together and we're being like, wow, this is miraculous for this particular patient type, for example. So that's what continues to get better. I feel like from a teaching standpoint, it's like now you could say, hey, Brett, what do you like from DNS and spinal stenosis? And I could rip off 5 different things. Whereas before we weren't good at doing that. Now we just have more context to like give people advice with the patients that are currently seen. And I do feel like too, like we've made it's way easier to apply than it was 15 years ago. We honestly, early on, we did a horrible job, myself included, at teaching it. But then like you just kind of get better if I think, I don't know if anyone's probably taught more DNS seminars in the last 15 years than me. And I feel like being out on the road and like have people ask me difficult questions, having some of my like kind of so-called enemies in the room to like question everything that I'm doing. It just kind of like makes you stronger and be able to go back and think about things differently. And that's, I think, what part of the process of making it, kind of change the way that it has for the better. Yeah. For those of us on the Western part of the world, probably getting more English instructors has also helped, maybe just because there can be a problem with like translation and stuff like that. So I feel like that also has probably been helpful for the Americans and Canadians probably.
Yeah. And one of my favorite things about like going to any of your courses, especially DNS though, is just like that applicability. Like you talk about clinical cases and we show practice patients, and you're saying, well, if this case comes in, this is what you do on Monday. And I think that's really helpful to like tie it all together, especially if it's your first DNS course, you're drinking through a fire hose. So what at this DNA course, like content based, like what is the meat of it? What are you kind of teaching? What should people expect?
Well, I think like the one thing that I feel like if people can buy into and really understand, like, and one of the main tenets of DNS is intra-abdominal pressure. So people know that, they give lip service to it, but I feel like very rarely do people actually understand that. So like if people can take that away from that's just the first day in A, it's well worth your money there. And then so once we've established exactly what that should look like with the patients, then we start building on developmental exercises from that. That's kind of the foundation. The other thing is a lot of the assessment and all of DNS is in the A course. So you learn how to like really look globally at the patient and look at, if we're talking about SFMA, that's like a movement assessment globally. DNS is more of like a stabilization assessment globally. So then it gives you some tools to kind of look at the body that way. To the patient thing, I always challenge myself to have really difficult patients there because I've learned that it's good pressure, and it also like you should have nothing to hide. And I actually learned this from Scott Bowie, who's one of the gurus in MDT. And he told me one time, he goes, my job when I work up a patient in a seminar is actually not to create a miracle. My job is to expose the system. And if I do a good job of doing that, then I did my job. Of course, we're all rooting for our patients to get better when we see them. But when you see a patient live in front of a bunch of people, really what you're wanting to actually accomplish is you're wanting to expose what the system is. And then hopefully you get lucky and you have a good result. But I think that's like the goal of, and we'll definitely in Nashville, we'll find some patients to work with, I'm sure. So that'll be a highlight of that. And then, I think it's one of my favorite courses to teach. I think it's like, it's really good. I mean, there's always fluff in every seminars, but I feel like in A, there's really not that much fluff. And what I like about A2 is on the Sunday morning, there's a 2-hour section on ontogenesis. And I've worked really hard to make that information applicable, where you're just not sitting there looking at a bunch of useless pediatric stuff that you're never going to use. Like always trying to tie that back to the adult patients and make that information a little bit more usable.
I like that you said, expose the system, because I don't know if you remember this, whenever I interned in your office, which was, that was like 12, 13 years ago now, that I was going to go take a DNS-A seminar, and you're like, I'm being honest with you, I would just kind of take what I've taught you in here and I would try to apply it for a while, because you even told me, you're like, it's hard to apply. And probably a lot of that was coming from like, it was hard to teach at that time. So it was like, and then when I took DNS-A, after I actually graduated, and then I was like, oh, I get what he was saying. Cause I left that seminar, I was like, I don't know. So I like that you're like, hey, we have more applicability. We have a systematic approach. You're leaving that seminar now like, oh, I know how I can implement this, what to look for in an assessment. So I think that's for anybody listening that's looking to go or hasn't gone, or even refreshing those skills, because it's evolving all the time, I would assume. Like that's the highlight now for me, is coming from, I kind of learned, Brett was just, I don't know, I got baptism by fire, like, hey, let's do this, let's do that. And then I was like, you go to the first course, like, oh, I get it. Like you saved me. Going back to you as an educator, and this is getting a little bit away from DNS, but like you've been a mentor to a ton of people. I mean, you have a ton of interns. I was an intern in there. You've been a mentor to Audra. And there's always kind of that like, ripple effect of like, you're actually having more of an effect on people because of the people you've taught. So it gives you a much, broader reach than you being like the best in the world. But I actually took your TMJ course, so this just speaks to you as an educator. And we were talking briefly before that you were probably most proud of your TMJ course. So I took that course. I thought I was decent at teaching TMJ, and then you literally in that course, you're like, man, this is a system. Like this is one of those things that I think you can have a playbook for. So here's my kind of, I guess sales pitch for that TMJ course, but just a fun story to tell. That during that course, you bring up a lot of research on, the one that I'm talking about now is migraines, and like the correlation or maybe, maybe causation of, TMJ dysfunction and migraines. In particular, migraines are, so idiopathic. So I had a patient that came in. She has had migraines since she was like 5 years old. She's now in her mid-50s. She's been treated with everything you can, medical cocktail and every treatment. And we literally run her through an exam. I actually ordered a full spine MRI to rule out, syrinx and some different things. And She comes back in and I'm like, one of the main functional findings that we found, which gets into the function play, was like, the 3-knuckle test. She looks like she's been chewing on leather. She's got giant masseters. Like, I was like, I think we should just run with this, even though she had no primary TMJ complaint, just migraines. And send her home with a McKinsey-esque approach to start. And she literally comes in the next time. She's like, I'm out of migraine sense. And just like, full mouth opening, running through it. And now we're over a month in and she's like off medication and stuff. And it's just one of those that you're like, it was almost, if you had no functional approach to lean on, I would have been completely lost because she had no symptoms, right, of TMD. Everything else was like peachy besides having these like almost constant headaches that would, flare up and down. So I talk about all that to go back to this mentorship piece that A, if I hadn't spent time in your office, B, if I didn't know who you were as an educator, and C, had I not taken that particular course, there's one case where I'm just like, well, I got to refer him out because I'm just lost. So when you approach like that TMJ course is kind of your course, do you feel like there's still gaps in your education that you're trying to fill that then help you be an educator? Or do you feel like you're kind of at that level now where you're like, man, I know there's always something you could learn, or you like, I really think I need to start pouring more out into, our profession and into our colleagues. And maybe it's a little more of your opinion, right? You're not necessarily just teaching DNS. We're not teaching MPI. It's more of like, hey, I've had a lot of swings and I've got some thoughts. Is that kind of where you're headed, or is it still, hey, we got these really good playbooks, why stray from it?
Oh, I feel like, it's like looking out in the ocean. I really feel like, now I probably like my biggest, now I see so many functional medicine cases now where like, I think one thing I'm kind of is amazing me currently at the moment is how many like middle-aged female menopause patients, difficult musculoskeletal cases are related to like fluctuations in estrogen, progesterone, testosterone, and like how important that is even in the musculoskeletal world is like a valuable lesson that I'm learning right now. So like I feel like the thing that I'm currently kind of amazed with is these patients that aren't responding well to the model, which usually, you plug in the model, the patients get better until they don't. And one of the reasons is because the body's so complex. It could be because of autoimmunity, it could be because of hormonal problems, metabolic, and like I think, for the aging clinician, you start to learn to appreciate those things a little bit more. And then I feel like as an educator, my job is not to go somewhere on a weekend and sound or look smart. My job is to, if I'm a bunch of try ones who are learning to adjust, I have to almost like just put myself back in that moment and be like, and not even talk about all the other things we could talk about. They need to learn how to palpate joint blockage and how to do an adjustment. Me sounding smart on the stage does nothing for them, So I think like always just trying to like be a chameleon and morph yourself to who the people that you're talking to are. That's what actually makes for good educators. And I feel like there's not enough of those people in the world like that are just willing to humble themselves and, talk to a bunch of try ones or try twos on how to get good at manipulation, And so to answer your question though, I feel like where I'm really learning a ton about is more like in the functional medicine side of it as it relates to musculoskeletal medicine and, like kind of filling that need for my patients and then educating the world on some of those thoughts is probably the, one of my future things besides the obvious stuff, like even like the TMJ, the more I'm around dentists and orthodontists and stuff like that, the more I'm learning about in their world, like whether that's palate expanders, whether that's tongue tie, whether that's, just surrounding myself with the right people to kind of like understand that. So I would say, oh no, it's like you think you get to a certain level and you just don't. Like you just want to learn more. You just keep, it's just like more. It's like this thirst that you just can't get enough of. But it's like fishing or golfing, and you catch a big fish or you have a great drive, and it's like it's just what keeps you going. And we always joke around here, you get absolutely your face kicked in and you're like, you leave the office like you're like, I just don't even want to do this anymore. And for some reason you wake up the next day and you want to do it again. It's like the coolest thing ever. And I think like if you can learn to treat all of your patients almost like a puzzle, and almost just love the process and revel in like the the complexity of it all. You never really burn out. You just like, you're like a little kid every day, just kind of like, oh my God, I cannot believe this connection. And that kind of gets you through dealing with all the difficult people, which we all have to deal with, which we're all of us see the same people in our day. They just have a different earth costume and a different name. But really, whether you're in Troy, Missouri, or Birmingham, or Nashville, or Sydney, Australia, like, we're all seeing the same people, So like, it's just like whatever we can do to continue to push the profession forward. So.
And I know, like a Gestalt, you guys combine the fun with the learning, and that's like a game changer. And that draws more people. And it's just like, I know I'm going to get to go have fun and network with other doctors and everything. And I know we're playing on the same thing. Thank you for, showing us that. Since you've been through this, like in a lot of other cities with your company, how important that is and what a game changer for people's like learning experience of combining, hey, we're going to hang out and have either intelligent or non-intelligent conversations, but have fun and like relax a little bit. And I know I walk away feeling like I learned way more, but then also got another level of like connection and networking and, oh, this was even more worth it.
Yeah, and I mean, I've definitely learned from like Taylor and some of our younger docs here, Pete and our other associates, Taylor and Austin now, where like they know how to have fun. I knew how to have fun like when I was in undergrad and things, but then like I took the first 10 years of my career and I mean, I put my head down and I just was a grinder. And now I'm different. I've kind of learned like it's actually, the world's a better place when we learn how to have fun. And it helps with the culture of the office. It helps with the culture of teaching. It just, I think that that's a special part of it. And I think that like it's understated, but 33% of your life is spent working, 33% of it's hopefully spent sleeping, and then you have your family, your hobbies and stuff like that. So if you're going to spend 33% of your life doing something, and you better be having fun doing it, or else it's going to be a long life. So.
Yeah. And what are you most excited for about coming to Nashville for this course?
Well, first of all, to hang out with you guys. So like that, as an educator, back to what Beau was saying earlier, like the biggest compliment for me is to see like people that, we've had an influence on, like go on and like lead our profession like you guys have. And, it's just like, to me, that's like so gratifying. And like, whenever I see like on social media, like you guys doing great things, it's like, it almost makes me blush because it makes me so proud. But, and then like, as far as like, Nashville's so fun. I mean, like, if you don't have fun in Nashville, that's your own problem. So, nothing's better than a night out on Broadway or day drinking in Nashville. So, I think Nashville's just kind of the new Las Vegas for us in the Midwest. And it's a great city. And then you surround yourself with great people like yourself. It's a recipe for a lot of education, but also a lot of fun. So that's probably what I'm looking. Yeah, now I'm old enough to where I kind of look for, am I going to a great spot? Do they have good wine there? Are the people good? And that kind of checks all boxes for me there in Nashville.
Well, and funny enough, you're part of the story of, Audra and I's whole run at an education company and why it's called Blackjack Education. Because, we spent a little time in the casino in Prague, and maybe they weren't as big of a fan of how we had fun as Americans as we were. So kind of what we're aiming for. So like you said, Nashville or Nash Vegas is kind of becoming this small, Midwestern or Southern Vegas. And that's a big aim of this is we know from, and I'm going to be honest, like I told Brett before this, like I've stole a page out of your playbook in terms of how our office runs. Like we have essentially communicated like group office for the docs, and like, there's a bar in there. It doesn't mean we're, drinking in between patients, but like we want an office where if you wanted to hang out here and talk about whatever it is or clinical stuff, you would feel comfortable doing that. And we know that's a game changer in other companies. So why not in the medical field where it can be a bit stodgy and, maybe uppity is not the right word, but it's like, oh, I'm a doctor and, this is a place of like higher learning that needs to smell like leather and mahogany or something. But, I stole a page from you, and that's what we want to also really focus on at these, courses, because it is 3 days of information. And you can attest to this. I know, Brett, on that third day, everybody looks like a deer in the headlights or a zombie, because it's not that it's bad information whatsoever. It's so much great information that you don't know what to do. So I think if you can keep the fun and the motivation and the networking high, that kind of offloads that pressure and, refreshes you a bit. So that's a big goal of Audra and I's for this upcoming seminar in April.
No, I think that is absolutely, and I learned that too in our office, actually. Because our center area was all divided up originally. And one day I'm like, you know what? I don't like this. I think we're just going to knock down the walls. So then we knocked down 2 walls to open it all up. And that's led to a sports book that we run out there, a full bar. It is just a disaster in there, but all I think in a good way. The new thing we're wanting a roulette wheel with the electronic readout. And we're going to have an omelet station, I think, and make the interns cook us omelets in a tuxedo, probably.
I love it.
Wow. We've got a ways to go to get to that echelon. So we got goals to strive for, at least.
Yeah. So anyways, the point back to, let's have a little bit of fun.
Yeah. Well, Audra, anything else, any, pressing questions, or are we leaving off on the fun component and, expecting everybody to just show up in Nashville now and, go sign up immediately after you listen to this?
I mean, I feel like we won that round.
Yeah. Oh yeah. I think so. Yep.
Well, to reiterate one more time, the person that I quote from a professional standpoint as a mentor the most in our office, or when I teach myself, is you. And the person I've probably learned the most from is you. And that's not just in the respective things that you teach for. It's overall, because I think you're a great integrator, which is one of the things that I want people to realize, that applicability means that you're able to integrate something like DNS into other tools you might have if it's in addition to. And I think you're one of the best in the world. And I think you're a king at that, like, hey, this is how you can apply this. This is how you can do this right now. Oh, you got these other things, like you can pay attention to this, but this is like, this gets you, further down the road. So that's what I'm looking forward to. I don't remember the last time I took DNSA. It's been a few years now. So it'll be cool to just kind of see what's changed, see you teach that. So I'm looking forward to it as well.
I second that.
Yeah, it's going to be a big thing. Yeah.
Well, not to be dog on this too much, but April 4th through the 6th, go check out blackjackeducation.com to sign up. Brett's going to be there signing autographs, besides teaching. And we got some gambling coming. I don't know if it's going to be a roulette wheel readout right in the seminar, but there'll definitely be some cards and some money thrown around for sure.
Well, I like where your head's at. That makes a lot of sense.
Yeah.
All right, guys. Well, if you have any questions, hit us up on social media. Anything else, Audra?
No, can't wait to see you.
All right. Thanks again, Brad, for being on here. We appreciate you, man.
Bye, team.
Yes. Yeah. Bye.
See ya.
Bye.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.